Okay, is my screen visible? Okay, thank you. So, I'm going to talk about thyroid disorders in pregnancy, and we'll go through the whole spectrum of the entire process, right from the physiology to the hypothyroidism, thyrotoxicosis, and some other disorders as well. I'm Dr. Om Lakhani. I'm a consultant endocrinologist at Zydus Hospital, and these are the details. Yeah. So let's first begin and understand the physiology of thyroid hormones in pregnancy. And this is the most important thing we need to understand when we are dealing with hypothyroidism in pregnancy. So, there are a few things you need to understand. What are the changes that happen during pregnancy? So one very important thing you have to understand is that there is an increase in HCG level during pregnancy. So this is a very, very important challenge. The problem with HCG is that HCG has a molecular similarity to TSH. So if the HCG levels are very high, this HCG can potentially act on the TSH receptor. And by acting on the TSH receptor, it can increase the T3 and T4 values. So this condition is known as gestational thyrotoxicosis, and this is not an uncommon condition that is seen in a lot of pregnant women. Then there is increase in thyroxine binding globulin. So there are patients who, in pregnancy there is increase of estrogen level, and estrogen increases the thyroxine binding globulin level. So one very important thing we have to understand is that when you measure total T3 and total T4 values, the values of total T3 and total T4 are increased in pregnancy, but the free T3 and free T4 values, they follow the regular trend. Also remember, there is increase in the volume of distribution, and because of this increased volume of distribution, the values can change. And there is increased requirement of thyroid hormone in pregnancy, and there is increased requirement of iodine during pregnancy. And because of that, women who have subclinical hypothyroidism, it can get worsened during pregnancy. And secondly, women who have iodine deficiency can get worsened in pregnancy. So if you look at the course of events, what happens during pregnancy, typically once the patient becomes pregnant, so in the first trimester, close to between first and the second trimester, about 10 weeks, there is reduction of TSH. Why does this reduction occur in TSH? This is because of the increase of HCG level, right? So the HCG level, is highest during 10 weeks of gestation, and because of that, the TSH level is the lowest during this point of time. Again, the TSH starts increasing and again reaches a plateau. So it's very important for doctors to understand that not only the thyroid function in pregnancy is important, but the thyroid function during which trimester of pregnancy is equally important. If you look at the free T4 value, again, it follows the trend exactly opposite to TSH. So if the TSH is low, obviously the free T4 values will be high. So again, close to 10 weeks of pregnancy, the free T4 values are at the peak, and then it gradually comes back to normal and reaches a plateau state. And we talked about thyroxine binding globulin. Also, it follows the same curve, and the thyroxine binding globulin persistently increases during pregnancy. But it's important to understand that the TBG, when you see, along with that, total T4 is the composite of the thyroid, which is bound to thyroxine binding globulin, and the free T4. So because of the increase of thyroxine binding globulin, the total T4 value increases during pregnancy and then ultimately reaches a plateau by close to second to third trimester. Okay, now it's very, very important to understand, like I said, that the values of thyroid function during pregnancy are different than in non-pregnancy state. This was already discussed in the a little bit in the previous discussion as well by Dr. Vivek Arya sir. So it's very important to understand the normal range during pregnancy. Now, see, the normal range interestingly also differs from which region you come from. So that's why the American Thyroid Association has suggested that you should have a local normative range depending on your region, because of the iodine status of the region may differ and the other issues may differ. Now, because of this, after this suggestion from ATA, there are many papers which have been published on local reference ranges, and this paper, this table comes from Dr. Rajput from Haryana, and he has published a normative range in pregnancy from Haryana. There are normative range available now from the northeast of India, from southern parts of India. Unfortunately, we do not have a data from west of India, but we were trying to create a consortium of both endocrinologists, physicians, and gynecologists to create a normative range. But so far we have not been successful in doing that. But hopefully in future we'll be creating a normative range for Gujarat or perhaps west of India, which would be very useful. So again, you can see from here what are the normal ranges during pregnancy in Haryana, and I think till we have the data from our center, similar data can be used. The one which is given by Dr. Rajput is a very interesting and very well conducted study. You can see the values here. You can take a screenshot of this if you are listening to this on an online virtual platform, and this is also available on the free paper. It's a free paper available on the Indian Journal of Endocrinology and Metabolism website. Okay, we already discussed that HCG and TSH have a very interesting relationship, and in pregnancy, remember, the HCG value increases, and along with the increase of HCG value, HCG starts acting on the TSH receptor, and because of that the T3 T4 values increase, the free T3 free T4 also increase, and because of that the TSH value declines. So close to 10 weeks of pregnancy, there is a dip in the TSH value when there is a maximum value of HCG. Now remember that women who have hyperemesis gravidarum, they have higher HCG levels. So a lot of the time women with hyperemesis gravidarum tend to come with gestational thyrotoxicosis. What is gestational thyrotoxicosis? We'll discuss this in the few slides later. So but this point you have to understand that because of the HCG during pregnancy, the TSH value sometimes declines. Okay, now let me tell you, this is a case somebody shared in one of the WhatsApp groups. So this is a 8-week pregnant female who is having this thyroid function. She is completely asymptomatic, and this test was done close to 8 to 9 weeks of pregnancy, just as a routine checkup, and patient is completely asymptomatic. Right now you can see the TSH value is very low. Remember, like I said, close to 10 weeks of pregnancy the TSH value is lowest, and this may be normal or abnormal. We'll discuss this in a later detail, but the reference range which is given here, this is given by the lab. Now this range is the range which is the reference range for non-pregnant female, right? So whenever you are dealing with your lab, it's very important to ask this to your lab that the reference range જે તમે reference range આપ્યું છે એ reference range pregnancy નું છે કે non-pregnancy નું છે. It's very, very important to ask this, right? And most of the time, most labs, except for some very good labs, they give a reference range which is for non-pregnant female. So this is a non-pregnancy reference range, right? Now, if you want to, and remember, like I told you, total T3 and total T4 increase during pregnancy, even in normal situations. So because of that, the reference range has to be pregnancy specific, but unfortunately they have not given us a pregnancy specific reference range. So how can you use Indian Jugaad to calculate the specific range? It's very simple. Take this value and multiply that by 1.5. So 11.7 into 1.5 will give you 17.5. So 17.5 can be said to be approximately upper limit of normal. And in terms of total T3, again you multiply the upper range 1.8 into 1.5, you'll get about 2.7, and this is the approximate value. So in this case, you can see the total T3 is in fact within the normal reference range, right, for pregnancy, because the upper limit is 2.7, and here T4 is slightly elevated more than the limit, upper limit, that is it is more than 17.5, that is 22.19. So what you have to understand is that the pregnancy reference ranges are different, and again if you see this value, remember the value is 22 and 2.3. Other option would be to ask the lab to do free T3 and free T4. Again you will have to use pregnancy range, because again for free T3 free T4 the pregnancy ranges are different. So ask your lab to provide the reference range, but if your lab does not provide, if you are using total, multiply by 1.5, and if you're using free T3 and free T4, use Dr. Rajput's chart, or in future if we develop Gujarat's own chart, I think we could be using that. Okay. A very important question is, when should you order thyroid function test in pregnancy, right? Like sir said, it has become a fashion to order thyroid function test in all pregnant women. Do we need to do that? Well, no. Answer is that you don't need to do it, but in certain cases you should do it, especially if you have somebody who is symptomatic meaning showing signs of hyper or hypothyroidism. Patient has a previous history of hypothyroidism. Patient has a previous history of TPO positive antibody, right? Like Dr. Arya was discussing, that somebody gets a TPO done, and if that is the case, it's a very good idea to check the thyroid function in pregnancy. Because subclinical hypothyroidism can become worse during pregnancy. If the patient has a family history of hypothyroidism, patient has undergone a head and neck irradiation, patient has a prior history of abortion, anti-TPO antibody has close relation with abortion. If the patient has a prior history of abortion, you can use, you should do a thyroid function test. History of preterm delivery, female who is obese, female with type 1 diabetes, or female coming from an area of severe iodine deficiency, especially, plain regions, there are certain regions of our country where iodine deficiency is very common, like hilly regions where Himachal Pradesh and all that areas where the iodine deficiency is very, very common even today. In fact, across the country, iodine deficiency is still very common. So in such cases, it should be a good idea to screen. So what is the impact of thyroid function on fetal brain development? And this is the reason why we are very, very concerned about thyroid function in pregnancy, because it can have an impact on the fetal brain development. So typically, if you see the relation between the thyroid function test and the fetal development, at about 5 weeks of gestation, the neurological development of the fetus starts. At 8 weeks, the thyroid receptors start getting in the central nervous system. The fetus starts having thyroid receptor, which is, so it's very interesting. By 8 weeks, the fetus requires thyroid hormone, right? But the fetus does not produce its thyroid hormone. The thyroid gland development only starts at 12 weeks, and the enough production, production which is good enough, the production starts at 16 weeks, and a production which is good enough starts at 18 weeks. So up till 18 weeks of pregnancy, the fetal development is dependent on maternal thyroid, right? If the mother is hypothyroid, the fetus will not have thyroid hormone, and the neurological development of the fetus up till 18 weeks of development requires thyroid hormone from the mother. By 18 weeks, the fetus starts developing its own thyroid hormone. So it is not dependent on the mother, but if the fetus also has hypothyroidism, then it's a problem, right? So that is something you need to keep in mind. So the neurological consequences of hypothyroidism are extremely, extremely severe. It can lead to mental retardation, low IQ, developmental delay, spasticity, deafness, right? It's a very serious problem, and this problem it's easily preventable by screening women for hypothyroidism, treating them adequately, and preventing this complication from developing. Remember, the thyroid is essential for brain development for the first 1,000 days of life. So even though up till 18 weeks, the fetus is completely dependent on the mother for thyroid, after that also the fetal brain development and neurological development is very, very, dependent on thyroid hormone, and up to 1,000 days of life, that is about, starting from the conception to, post-birth, about up to 3 years of life, the fetus is very much dependent on thyroid hormone for its, the child is very much important on the thyroid hormone for its neurological development. And because of this, remember, congenital hypothyroidism is a very, very, very important cause of preventable mental retardation worldwide. So this is something very important, and it's my folded request to all of you, like we do vaccination in children. In Western countries, it is now mandatory that all children who are born, they undergo certain screening tests for congenital disorders. And one very important screening test for congenital disorder is congenital hypothyroidism, right? So all children born must be screened for congenital hypothyroidism. Please, if you have friends, family, patients, relatives, anybody who is pregnant, whether the mother has hypothyroidism, hyperthyroidism, doesn't matter. All children born, all neonates at about 48 to 72 hours of life must undergo screening for congenital hypothyroidism. This is a must. It is as important as vaccination. It is as important as other precautions. It is as important as breastfeeding, right? Because, 1 in 3,000 children have congenital hypothyroidism, and if it is diagnosed at the right time, you can completely change the life of this child. Otherwise, the child becomes mentally retarded, child becomes what is known as cretin, and unfortunately, unfortunately, the child's life is now destroyed. So it can be easily prevented by screening children at birth. There are a lot of data which has shown that even uncontrolled hypothyroidism can lead to low IQ, autism, schizophrenia, and other things. About 7 point. So if you have an infant with untreated hypothyroidism, there is 7-point reduction in IQ. This is the study done from Haddo. So this section, the key points is thyroid function values differ from non-pregnancy state. It is very important to understand the pregnancy-specific thyroid values, and untreated hypothyroidism can have very severe consequences for the fetus. Now let's talk about hypothyroidism in pregnancy. Right now, this is a topic which it looks very simple, but it's actually very, very controversial, right? There's a lot of controversy in this area, and there is, in fact, a recent change in the guidelines which has completely changed how we approach hypothyroidism in pregnancy. Now, first we need to understand the difference between overt hypothyroidism and subclinical hypothyroidism. So whenever you have, what is overt hypothyroidism? So remember, we had Dr. Vivek Arya talk about hypothyroidism, subclinical hypothyroidism in non-pregnancy, but the definition of overt and subclinical hypothyroidism in pregnancy is little different. Now, typically, overt hypothyroidism in pregnancy is defined when the TSH is above the trimester specific range and the patient has low T4. So we talked about, the trimester specific upper limits from Dr. Rajput study or from the local data if we have. If it is above this value, the patient is said to have overt hypothyroidism. We don't need to wait till 10 TSH, this above the upper limit of normal for the pregnancy level. Typically, the average value in first trimester is 4. So if you don't have any other value, you can use 4 as the data. But if you have local values available, that is what we can use. And subclinical hypothyroidism is when TSH is above the specific range with normal T4. So this is the definition. So if low T4, you have overt, and subclinical hypothyroidism when you have normal T4. Now, earlier guidelines, they used to have a cutoff in pregnancy for hypothyroidism as 2.5, 3 and 3 in first, second and third trimester. But the new guidelines say that the above cutoff are perhaps not the good idea, and perhaps you should use local cutoffs which are available in your population. But if you don't have local cutoffs, then you can use upper limit of normal of TSH as 4. So the cutoffs have now changed from 2.5 to 4. Now we still use 2.5 and 3 as targets, but for treatment decision making, we use now 4 as a cutoff, or if you have a local guideline, use the cutoff. Now I know it is sounding a little confusing, but I promise you I'll make it very simple for you at the end of this. In fact, I'll make it very, very simple for you if we go along, right? So like I told you, we need to use the local cutoff values, and this is the data from Dr. Rajput. Once again, I'm showing the same slide again. The TSH value, if we take the upper limit as 97.5 centile, in first trimester, the value in Haryana is 3.69. In second trimester, it is 4.47, and in the third trimester, it is 4.64. So typically, ATSAs, you use the value of 4. In India, probably you can use 3.69 as a cutoff or 3.7 as a cutoff of the upper limit of normal. Right, so simple value, either you can just remember 3.7 or you can remember 4. Either it's one of the two values is fine for you to remember. Now, this is the simple chart which you should understand. So again, this is a chart which is made by me. You will not find this chart elsewhere. You can take a screenshot of this. Right, this will simplify as simple as possible. We have made this for you to understand. So remember, let's say you measure the TSH. First of all, let's assume we are measuring the TSH in the first trimester, and that is where you generally measure the thyroid function in women during pregnancy. So if the TSH is more than 10, absolutely treatment is a must. All these patients should be treated, and the treatment should be full therapeutic dose of levothyroxine, that is 1.6 microgram per kg per day. You don't see, in pregnancy, time is very, very crucial, and you don't have the liberty of waiting to increase the dose or waiting to up titrate the dose. Directly start with the full therapeutic dose of 1.6 microgram per kg. Now on the other hand, if the TSH is between 4 to 10, then you measure the anti-TPO antibody, and it's very important here to measure. Anti-TPO has a very important role in pregnancy. So measure the anti-TPO antibody. If it is negative, we don't know. The data is not very certain whether you should treat or not, right? But in my clinical practice, I generally treat this patient, and generally, we consider treatment. But if the anti-TPO antibody is positive, definitely treatment must be given. And again, the dose you should give here is 1 microgram per kg. Again, you should start full therapeutic dose of 1 microgram per kg and not wait for starting with a small dose and up titrating. Directly start 1 microgram per kg. Now, if the TSH is between 2.5 to 4, again you measure the anti-TPO antibody, and if it is positive, then you take clinical scenario. Does the patient have a previous history of abortion? Does the patient have twin pregnancy? Is this a IVF conception? If all these situations are there, then treatment must be given. However, if there is such situations are not there, then according to the new guidelines, treatment is not necessary. And if the anti-TPO is negative and the TSH is between 2.5 to 4, then no treatment is indicated. And the last category, if the TSH is less than 2.5, then absolutely no treatment is required, unless of course, we're talking about hypothyroidism. Unless the patient has hyperthyroidism, then it's a different question. But hypothyroidism, you don't need to treat for hypothyroidism, right? Now, like I said, I promised you I'll make things as simple as possible. So actually written a small program in Python. Now, unfortunately, we're not, this is, there are restrictions to sharing this, because of medical issues, but if possible, whenever possible, I will be able to share this program with you. So in this, we have written a small Python program. In Python is a computer programming language. We have written a small program to help you make a clinical decision about treating hypothyroidism in pregnancy or not. So it will ask you this question: what is the TSH value? So let's say the patient has a TSH value of 5, so you put 5.0 as the value. It will ask you, is anti-TPO positive or negative? So let's say if the anti-TPO is positive, it will ask you whether the patient has twin pregnancy or not. Let's say there is no twin pregnancy, there is no history of recurrent abortion, there is no history of IVF, then the decision will be patient needs to be treated. So the TSH value is between 4 to 10 and anti-TPO is positive, then there is indication for treatment, and the levothyroxine value should be 1 microgram per kg. Let's choose another scenario. Let's say TSH value is 10, anti-TPO is positive, the patient does not have twin pregnancy, no recurrent abortion, no IVF. Again, it suggests that you should start, but you should start the treatment with 1.6 microgram per kg. So it's a very simple Python program, but very effective for making this clinical decision. Okay, so moving ahead, it's also very important to understand that hypothyroidism is also associated with infertility. I think this was also discussed a little bit with Dr. Vivek Arya sir, and I will be discussing other cases as well. So hypothyroidism can lead to anovulation, and especially both hypothyroidism as well as untreated hypothyroidism as well as anti-TPO antibody positivity can lead to first trimester abortion. So that is something very important, and that should be kept in mind while again keeping away. So even if women have, if the women have history of recurrent first trimester abortion in the past, in such cases you should consider treatment with levothyroxine in small doses if the anti-TPO is positive, right? So this is again a different issue, but that's also something you keep in mind. What are the complications of hypothyroidism in pregnancy if you don't treat it? You can have abortion, preterm delivery, increased perinatal morbidity, hypertension in pregnancy, increased risk of placental abruption, LSES, postpartum hemorrhage, and for the fetus, very importantly, neurocognitive impairment. Okay. Sorry. Yeah. So, let's say again, take another scenario where a woman with already pre-existing hypothyroidism. So there's a lady with hypothyroidism pre-existing, and she becomes pregnant. What should you do? So, or she's planning to become pregnant. What should you do? So most of those cases, the pregnancy, if you're planning for, the patient is planning for pregnancy, a patient comes to me saying that, we're planning for pregnancy and patient is on my follow-up. I typically sometimes increase the dose of levothyroxine, generally try to keep TSH of target less than 2.5. So target still remains 2.5 in first trimester, 3 in second trimester. So if you're treating this patient, it's a very good idea to keep TSH as low as possible. Remember, in pregnancy, the thyroid hormone requirement increases, and because if the increase in requirement, you might need to give more dose. Again, as soon as the pregnancy is confirmed, you need to increase the dose. This is very, very important. And most of the time we increase the dose by 30%. So very simple formula is, if the patient is taking 7 tablets, remember the thyroid hormone has a long half-life, and generally the treatment is on weekly doses. So we give, actually it's a weekly dose divided into daily doses. So if the patient is taking, let's say 100 microgram every day, 7 days a week, instead of 7 tablets, we make it 9 tablets. So generally simple thing, take 100 microgram daily, but on Saturday, Sunday, take 200 microgram. It's a very simple calculation we should do. If the patient is taking 50 microgram, and the TSH is controlled, then we say take 50 microgram daily, but on Saturday and Sunday take 100 microgram. So on 2 days of the week, on the weekends, generally you can increase the dose, double the dose. So instead of 7 tablets, you give 9 tablets in a week. And that's a very simple calculation for increasing the thyroid dose in pregnancy in women who are already hypothyroid on treatment, right? We know why this thyroid hormone increases during pregnancy. We already discussed this. There is increase of thyroxine binding globulin. There is, remember, the fetus is also dependent on the thyroid of the mother. So some of it gets transferred to the fetus. There is reduced iodine during, the women's iodine requirement increases, and if this dietary iodine is not able to sufficiently provide, then there is a reduction in iodine levels. There is some destruction of the T4 by the placenta, and there is reduced absorption of the thyroid hormone, because of a lot of the time these women are on calcium tablets or iron tablets given by gynecologist, and because of this the requirement this can interfere with the absorption of the levothyroxine tablet, and can hence you may need a higher dose during pregnancy. Typically, we already discussed this. If you are having hypothyroidism of any reason, right, directly start with full therapeutic dose. But if the TSH is less than 10, or if you have subclinical hypothyroidism, in that case you can start 1 microgram per kg, right? So this is the doses you have to keep in mind. How frequently should you monitor? Well, you should monitor every monthly, at least till mid gestation, and then once. So generally till 18 weeks of pregnancy, we generally measure every month. Right, during pregnancy, non-pregnancy state, we may measure every 2 months or 3 months, but in pregnancy, it is always a good idea to measure every month. And if you are, after 30 weeks, once you are, after 18 to 30 weeks, you can measure every 4 to 6 weeks, and then after that, you can take a call depending on the clinical situation. Once the patient delivers, then again, the thyroid hormone requirement will reduce. And again, you reduce by 30%. So whatever dose the patient was taking by 6 weeks post gestation, you reduce the dose by 30%. Sometimes some women may have worsening of hypothyroidism after delivery. In such cases, you may have to increase the dose also. So that would depend on case to case scenario. But again, preemptively, we generally reduce the dose after delivery, and then we call the patient back, and then we take a call based on the situation which is happening. Sometimes uncontrolled hypothyroidism may be associated with poor lactation. So again, this is something, so if you have a woman with history of hypothyroidism in pregnancy, coming with poor lactation, again, it would be a good idea to check the thyroid function. Right. So as far as hypothyroidism in pregnancy is concerned, the important point is that all women with TSH more than 10 must be started with hypothyroidism treatment with full therapeutic dose of 1.6 microgram per kg. Women with pre-existing hypothyroidism, their doses must be increased during pregnancy or sometimes preemptively. And untreated hypothyroidism, remember, can have very serious consequences on the fetus, leading to low IQ and cognitive decline. Now let's talk about thyrotoxicosis in pregnancy, the other side of the spectrum, right? Now this is a very serious condition, right? And this is something, you have to be very careful in treating, because if you treat the wrong way, you have disastrous consequences. We have seen a lot of disastrous consequences with wrongly treated thyrotoxicosis in pregnancy. So what are the complications of hyperthyroidism or thyrotoxicosis in pregnancy? So again, thyrotoxicosis in pregnancy is also detrimental. It can also lead to abortion, low birth weight, premature labor, stillbirth, preeclampsia, heart failure for the lady as well. So these are all serious consequences which can happen. So, as far as the etiology of the thyrotoxicosis in pregnancy is concerned, remember, all cases of thyrotoxicosis in pregnancy are not Graves' disease. Graves' disease is an important cause, but you have also a condition known as HCG mediated hyperthyroidism, which is transient gestational thyrotoxicosis. You have another hyperemesis gravidarum can also lead to transient thyrotoxicosis, trophoblastic disease, right? And familial gestational hypothyroidism, these are other causes. So broadly speaking, the two major causes of hyperthyroidism in pregnancy or thyrotoxicosis in pregnancy are Graves' disease and gestational thyrotoxicosis. These are the two most important causes. The other ones are, trophoblastic hyperthyroidism, and these are all very, very rare. So, we generally, don't worry about those, but the two ones we have to really worry about are Graves' disease and gestational thyrotoxicosis. Now, first thing, before we do further testing, I again request you with my folded hands, please do a complete thyroid function test before you consider treating patients with hyperthyroidism in pregnancy for any reason. A lot of the times we see that somebody does a thyroid function test in pregnancy, the TSH is low, and directly the patient is started on treatment, and the patient ends up with hypothyroidism, iatrogenic hypothyroidism, which is very, very serious condition. Again, lead to fetal low IQ, and so on and so forth. And these are potential grounds for litigation also. So before you take any clinical decision on what to do, always do a complete thyroid function test in pregnancy. Don't just do TSH if you're dealing with hypothyroidism. Plus minus, it's an arguable thing. I would again suggest to do a complete thyroid function test in hypothyroidism also, but in hyperthyroidism or thyrotoxicosis, 100% you have to do complete thyroid function test. You cannot just rely on the T4 value. But also it is very important that you do not treat all cases of thyrotoxicosis in pregnancy. You need to differentiate whether it is Graves' disease or gestational thyrotoxicosis. Gestational thyrotoxicosis generally does not need treatment, whereas Graves' disease need to be treated. Whenever in doubt, again, it is my recommendation that these patients, whenever you have thyrotoxicosis in pregnancy, please refer them to endocrinologists. Not even physicians. I have seen physicians make serious errors with this issue. I have seen gynecologists make serious errors. Sorry to say, this is the reality. I'm not blaming anybody. This is how things roll. But the point is that whenever you have thyrotoxicosis in pregnancy and whenever in doubt, it is always a good idea to refer these patients directly to endocrinologists, because these are very critical issues where it can lead to, either way, can lead to serious consequences. In such patients where you have thyrotoxicosis in pregnancy, one very useful test is TSH receptor antibody. Now, a lot of people don't know that this test is now easily available in Ahmedabad. It is now available in most big cities in the country, and most major labs in India do it. In Ahmedabad, most major labs do it. This is a very simple test. It doesn't require fasting, simple blood test. It's an antibody test. It is done. It costs about 3,000 rupees. But most good labs in India do it, and most good labs in Ahmedabad 100% do it. So if you have a patient with thyrotoxicosis in pregnancy, it is always a good idea to do a TSH receptor antibody testing. Why this is important? Because if TSH receptor antibody is positive, that is suggestive of Graves' disease, and in such cases you require treatment. Whereas if the TSH receptor antibody is negative, it is very good likely that the patient has gestational thyrotoxicosis, which does not require treatment. Secondly, whenever you have thyrotoxicosis in pregnancy, there is no role of anti-TPO or anti-TG antibody. It's a waste of money. You can do it. It is not going to change your management. You're just wasting the patient's money, or wasting, the patient is wasting their money. Doesn't matter, right? So it's not a good test to do in thyrotoxicosis. For hypothyroidism in pregnancy, anti-TPO is a useful test, but for thyrotoxicosis in pregnancy, anti-TPO is little or no role. However, the test you should consider doing is a TSH receptor antibody. Right? Again, we discussed this point, HCG and TSH relation. HCG is at a peak at about 10 weeks of gestation, and it falls by about 14 to 18 weeks. So generally the TSH in natural pregnancy also may be lower during this period of time. Right? Remember this chart, keep this imprinted in your mind. It's very important. During close to 10 weeks of gestation, the TSH value is low and the HCG value is high. Right? So which patients with hyperthyroidism in pregnancy are treated? So those women who have severe hyperthyroidism due to Graves' disease, or very rarely you have H mole, hydatidiform mole or something, such cases need to be treated. And again, patients with mild hyperthyroidism where the T3, T4 is less than 1.5 times the upper limit of normal are not treated. Remember, it's a tightrope. It's a very important thing to understand that treating hyperthyroidism in pregnancy is a tightrope. If you go one side, if you undertreat the patient has problem. If you overtreat the patient develops hypothyroidism, the fetus develops hypothyroidism, and the fetal can have neurological consequences and low IQ and mental retardation. So again, like I said, if you have hyperthyroidism in pregnancy, such patients should be always referred to endocrinologist, not to physicians, not to gynecologists, because it's a tightrope, and falling either ways can have disastrous consequences for the pregnancy, for the mother, for the fetus, for the whole family, right? So it's something we have to be very careful when you're dealing with this, right? The treatment target whenever you're treating this patient is to keep the T3 and T4 just close to the upper limit of normal. Over treating it, like I said, can lead to again hypothyroidism, which can be a problem. Generally don't need beta blockers in these cases. Again, beta blockers can have serious side effects. So unless absolutely patient having very severe cases, we generally don't give beta blockers. And a beta blocker can lead to bradycardia, hypoglycemia, low birth weight in children, in the fetus, which can be serious. And again, you need to be very careful before you prescribe beta blockers, and you don't give it unless it is absolutely necessary. The as far as the drugs are concerned, so let's say you're decided to treat the patient with Graves' disease in pregnancy. Remember, in the first trimester, it is important to use PTU and not methimazole. Actually, both PTU and methimazole cross the placenta, but methimazole or carbimazole is known to produce teratogenic side effects. Right? This is known as this is aplasia cutis, which is a very common side effect, teratogenic side effect of methimazole and carbimazole if it is given during first trimester. So in first trimester of pregnancy, methimazole or carbimazole should be avoided. And let's say there are women who already have Graves' disease before they become pregnant, and they become pregnant accidentally or unplanned pregnancy. In again such cases, in the first trimester, you need to shift the patient from methimazole or carbimazole to propylthiouracil PTU. The problem, there are other, of course, teratogenic side effects of methimazole or carbimazole, cloinal atresia, tracheoesophageal fistula, and all the other things. These are rare, but these can potentially happen. And teratogenicity is very, very problematic. A lot of medical legal cases can arise because of that. The problem is, however, the PTU is also not a very safe drug, unfortunately, and PTU can lead to sometimes idiosyncratic hepatotoxicity, which can happen to anybody. It is unexplained and it can be even serious, life-threatening, may even cause death. So generally what we do is, in the first trimester we use PTU, but in the second and third trimester we shift the patient back to carbimazole or methimazole, because after second or third trimester there is no risk of teratogenicity. So we generally shift the patient back to carbimazole, methimazole, because in terms of liver toxicity, the carbimazole and methimazole is lesser of the two evil, and PTU can lead to severe hepatotoxicity, whereas methimazole can only lead to cholestatic hepatitis, which is generally much easier to treat. Like I said, in the first trimester it is better to give PTU, whereas in second and third trimester it is better to switch the patient back to methimazole or carbimazole. Okay, typically, again, we have often seen that patients are over aggressively treated, leading to hypothyroidism. So always we talked about hypothyroidism pregnancy, always start with the full therapeutic dose, but in hyperthyroidism in pregnancy, give lowest possible dose. When you're giving PTU, give 50 milligram 3 times a day. If your patient is already in second or third trimester and starting methimazole or carbimazole, you generally start with about 5 to 15 milligram of carbimazole or 5 to 10 milligram of methimazole. Right? The consequences, like I said, of both over and under treatment are serious. Over treatment can lead to fetal hypothyroidism, which can again lead to mental retardation. Under treatment can, of course, lead to the other consequences like abortion and other problems in heart failure, so on and so forth. Right? So this is the course of Graves' disease during pregnancy, and sometimes the symptoms are aggravated in the first trimester, then it becomes static, and postpartum sometimes you could have two things. Sometimes it can get worsened and sometimes it becomes quiescent. So remember, these are autoimmune diseases and they can have a changing nature with the pregnancy and post-pregnancy situation. So the key messages with regard to thyrotoxicosis in pregnancy is, remember, always do a complete thyroid function test in thyrotoxicosis in pregnancy. All patients with thyrotoxicosis in pregnancy do not require anti-thyroid drug. Remember, a lot of these women may have gestational thyrotoxicosis which does not need treatment, and TSH receptor antibody is an important test. It is available in Ahmedabad, and please, always better to do it. It doesn't cost 3,000 rupees, is nothing compared to the life of a child. And in case of Graves' disease in pregnancy, always it is better to refer this patient to an endocrinologist directly rather than other specialties. Again, let's summarize all the points which we discussed today. Remember, thyroid function values in pregnancy differ from non-pregnancy state. It's very important to know the physiology of thyroid in pregnancy. And untreated hypothyroidism in pregnancy can lead to low IQ and cognitive decline. As far as hypothyroidism in pregnancy is concerned, all women with TSH more than 10 definitely treated with full therapeutic dose. Between 4 to 10, the clinical decision making may differ, and those with pre-existing hypothyroidism increase the dose during pregnancy, and untreated hypothyroidism in pregnancy can lead to low IQ, cognitive decline, and we already discussed this about thyrotoxicosis in pregnancy. So finally, one last slide. We have developed this app called Notes in Endocrinology. All this, what I discussed today, all aspects of thyroid in pregnancy, the physiology, the hypothyroidism in pregnancy, hyperthyroidism in pregnancy, some other topics. They are all available on this app, right? It's a free app. It's easily, you can, it's available both in Android as well as in Apple. But Apple, we are unfortunately, the membership has expired and we just renewed it. So it may not be available for at least a couple of weeks in Apple, but it will soon be available again there. And it is available on Android. It is also, you can go to the website. It is www.endocrinology.co.in. You have whatever we discussed today. It's all going to be available. There are a lot of videos, and future, this app which we developed, this Python program which we made for hypothyroidism in pregnancy will also be available on the same website once we are, start distributing it soon. So all this will be, all resources and all, of course, a lot of other notes in other endocrinology subjects are all available. There's plenty of material there. So I thank you for a patient listening, and thank you again to the Family Physicians Association who are inviting me today for this talk.